everyone. My name is Alex Schadenberg. I'm the Executive Director of the Euthanasia Prevention Coalition. So euthanasia, or MAID as we call it in Canada, was legalized in Canada in June 2016. So we're now in June of 2024. It's been 8 years. We created an exception to homicide in the criminal code. So I know it's being dealt with in Canada as a medical treatment question, but remember, it's actually an exception in our criminal code to homicide. And you can see that right in the criminal code. The law gave physicians and nurse practitioners the right in law to kill you or to cause your death. So both euthanasia and assisted suicide were legalized. The law was expanded in March of 2021. That was Bill C7. And what we did is the Canadian government, our government removed the terminal illness requirement in the law. So the original law said that your natural death had to be reasonably foreseeable. That was removed in March of 2021. But by doing that, they also then created a two-tier law. So I'm going to go into that 1 second. They also removed the 10-day waiting period for someone who is terminally ill. And they permitted euthanasia for mental illness alone. As you know, there's been a lot of debate around that question because as of this moment, it's been delayed until March of 2027, the allowance of euthanasia for mental illness alone. So when I'm talking about this, you have to understand euthanasia for mental illness in Canada is allowed, but someone would have to have a comorbidity. They'd have to have another condition that they're being approved for. So mental illness is only then a related condition. It's not condition alone, which is what Bill C7 actually allowed for. That won't be into place until March of 27, hopefully never actually. When we removed the terminal illness requirement, our federal government created a two-tier law. So they have a track 1 and a track 2. So if a person is deemed to be terminally ill, once again, they use this definition that your natural death is reasonably foreseeable. The problem with that definition is it's never been really defined. Anyway, if you're deemed to be terminally ill, there's no waiting period. And if you're deemed that you're not terminally ill, that you have a chronic condition, but you're not terminally ill, that would be a track 2 case. And then you'd have a 90-day waiting period. When Bill C7 was being debated, the disability community were right when they said, why us? When you remove the track 1 only cases and you add track 2, who's now qualifying under these cases? These are people with chronic conditions. What was left in the law when you removed the terminal illness requirement, natural death being reasonably foreseeable, what was left in the law is that you had to have an irremediable medical condition. And what is an irremediable medical condition? There are lots of people who have an irremediable medical condition, absolutely. And so what it means is that if you're determined that you're not terminally ill, but you have a condition which is not going to get better, it's irremediable, and it is causing you to suffer. Remember, suffering is a subjective term, because if you tell your doctor you're suffering, your doctor can't tell you you're not. Your doctor's not inside your body. Your doctor does not understand if you are suffering or not suffering. It's not possible for them to know, right? It's a personal, subjective thing. So anyway, you would have to be suffering, etc. And the fact of it is this is why we've had a lot of these deaths that I'm going to get into in a minute. The data showed that as of 2022, we had 13,241 reported assisted deaths. I say reported because if you look at the Quebec data, Quebec has their own report. It does show some level of underreporting that's going on. The problem is you can't know if there's underreporting unless you do an investigation into that, right? We do not have the 2023 data yet, but if you read my articles, you will have noticed that I had the Ontario data, the Quebec data, data from Nova Scotia, Alberta, and Manitoba and a few other places. So I predicted that we had about 16,000. It might be a bit high, that 16,000 number, but certainly we were in the range of around 16,000 euthanasia deaths in 2023. What's crazy is we're in June of 2024, and we don't have a federal report telling us how many deaths occurred in 2023. That is pretty ridiculous. In 2023, Quebec had 5,686 euthanasia deaths, representing 7.3% of all deaths. That was the highest in the world. Why is that so significant to me? Canada legalized this, or Quebec legalized it a little bit earlier than the rest of Canada. You know, there's two laws in Canada. There's the Quebec law and the federal law. But Quebec legalized in 2015. It came into place in December of 2015. So it's been a little over 8 years for Quebec. Netherlands legalized in 2001, and the law came into place in January of 2002. So you understand the fact that 7.3% of all deaths being much higher than the Netherlands euthanasia rate is significant. We've had lots of cases. Now, where do these cases come from? There's actually many more. I'm just going to give you a few of them. These cases come from these track 2 situations, people who are not terminally ill. They're asking for euthanasia not based on being terminally ill, but based on other conditions leading to this. So there was the 51-year-old woman in Ontario who died by euthanasia because she had multiple chemical sensitivities. Now, let's be very clear about this case. The other side, the euthanasia lobby, has said yes, but this woman actually thanked the doctor for approving her euthanasia death. But if you go into this question, why was a woman with MCS who could clearly have been treated, meaning what's the treatment for MCS, multiple chemical sensitivities? It's a clean place to live. That's what it is. She needed a place. She was living in social housing. Social housing was probably not the best place for her, considering she reacted to so many chemicals in her environment. Probably not a good place for her. She needed a clean place to live. Instead, she died by euthanasia. Why would she be approved? I'm not questioning that she was suffering in some way, but she had a treatable condition. Then there was the 31-year-old woman. Now we have to put this into place. This happened where the 31-year-old woman came out in the media about this. She also had MCS. And that happened just after the 51-year-old woman died. So you get what you call sort of like a repeat situation where one person dies by euthanasia, so therefore another person applies for it based on the same condition. The question really was, why were these people approved to be killed? This is the greater question. We had the case of the 23-year-old Ontario man with diabetes. So that was the Keanu. Keanu was 23 years old. He was diabetic. During COVID, he had stopped taking his insulin, and he had some clear health problems related to that. But if you remember watching the W5 show where they interviewed Keanu, you realize he was quite good at riding his skateboard around. He looked quite good. So yes, he had lost some of his eyesight. Yes, he had had some health effects, but he was, reasonably healthy. He had been approved for euthanasia. His mother saved his life because she came out very angry with the fact that her son, who was 23, who was a diabetic, was approved to be killed. She could not believe this. So she went to the Ministry of Health, she went to the media, etc. She started a petition. She named the doctor who had approved him and who was planning to do the death at the Maid House in Toronto. And in the end, the doctor decided not to kill her son. Amir Farsu, you see him here. He's a man from St. Catharines who was told that his building was going to be repaired, etc. He had to leave. He is a disabled man who was on social housing assistance, so he could not find an apartment that he could afford with his disability benefit. Now we have to understand this is what a lot of people in Ontario go through, meaning that if you don't have subsidized housing, how can you live on your disability benefit? How is it even possible in Ontario? So he had subsidized housing, but by moving, he would lose his subsidized housing space. So he applied for euthanasia and was approved for euthanasia based on his disability. He did not want to die. He was just saying he was in fear of being homeless. In the end, a GoFundMe campaign raised money for him, and he has a place to live. The veterans issue. It's almost embarrassing that as Canadians, we had veterans who had served our country in Afghanistan and other places who had PTSD, they had traumatic stress disorder, who were contacting Veterans Affairs for help and who were being told they can ask for euthanasia. Like, if you think about that, that is really beyond the pale, right? That is just unbelievable. These are people who served our country. Some of them went to Afghanistan. They didn't want to go to Afghanistan. They were serving our country. They didn't want to experience what they experienced, but they did so. They did so on our behalf. Anyway, this was ridiculous. Of course, what happened in that case is our Veterans Affairs Minister, Lawrence MacAulay, had a press conference at the time, and he said that this was one bad case. So he told the media this was one bad case. It was one rogue employee. This had happened, and this was wrong. It would never happen again. And what happened, of course, is by him going to the media, you had a situation where other veterans who had also been told to consider euthanasia came forward. So we learned that there was minimally 6 cases, that there was minimally 2 who had died by euthanasia. There might have been many more than 6. We don't know because we only know the ones who came forward, right? That's all we have. And then that seemed to settle down, and then Christine Gauthier came to the media. Now, Christine Gauthier is a retired Canadian soldier who, after while serving our country, she became disabled. She became a Paralympic athlete. She was asking Veterans Affairs for help with a wheelchair lift to enable her to be able to live in her house, right? And she was being told no. Now, she was actually being quite strong about the situation because she knew she qualified for assistance in getting wheelchair lift. And I personally, now it's only my opinion, I don't think it's unreasonable that someone who served your country, who became disabled serving your country, is needing a wheelchair lift. Should be, I don't think it's unreasonable to ask for assistance for a wheelchair lift. You know, you guys might disagree with me, but I think that's quite reasonable. Anyway, she was told by Veterans Affairs, Madam, if you're really so desperate, we can give you medical assistance in dying. Catherine Mentler, this case was in June of 2023, where she went to Vancouver General Hospital. She's a woman. She at the time was 37. She'd experienced suicidal ideation many times before. So she was going to Vancouver General Hospital for help. She knew she needed help. She was wanting to avoid her feelings of suicidal ideation. What happened is at the Vancouver General Hospital, a counselor met with her and told her there were no available beds. So this was immediately telling us that in June of 2023, the psychiatric beds were full in Vancouver. That's what it's basically saying. They said there's no available beds, and the earliest that she was able to see a psychiatrist was November. So you start doing your counting, June to November. It's about 5 months. And then she was asked if she had ever considered medically assisted suicide. So we think about that. Someone might say, well, maybe that's an interesting indicator as to how suicidal she is. But the fact of it is someone who's coming to you for help, who's experiencing suicidal ideation, who's identifying they're going through a serious mental health crisis, you don't ask them about assisted suicide, right? That's not the answer to their issue. They're seeking help. Now, these are more recent stories. I have them in sort of an order because Alison DeCluso was the first story that hit the media. Alison DeCluso was diagnosed with abdominal cancer. She was offered euthanasia rather than treatment. Now, she lives in Victoria, BC. The picture you see on the right is her with her new husband on their honeymoon. So what happened is DeCluso did not accept that there was no treatment for her abdominal cancer. She contacted several cancer institutes in the US. She ended up going to the Institute for Cancer Care at Mercy Medical Center in Baltimore. She went into full remission. She got married, and as I say, that's her new husband there. Um, and so why her story ended up in the media was she was challenging the British Columbia Health Ministry. She was saying to them that they need to pay for her cancer treatment because they did not offer her treatment in BC. They offered her euthanasia. They didn't offer her treatment. She had to go to Baltimore to get her treatment. And so I'm not sure actually how that settled. I actually looked that up, put her name in the Google system, see what Google comes up with. But the point of it is that when that article hit the newspaper, then we found out about Mary Griffin, because once one story hits the papers, new stories hit. So Mary Griffin of Victoria, BC, died by euthanasia after she was forced to wait 10 weeks to see an oncologist. So she died on March 17th, 2023. So what happened with her is that she had cancer, but it took her 10 weeks to get her appointment with the oncologist. And when the oncologist saw her, the oncologist said, I wish I had seen you earlier. She ended up dying by euthanasia, did not receive treatment, showing you there's a problem in the system. Okay, there's a serious problem in the system. And this problem in the system for treatment has resulted in people dying by euthanasia. Then the story of Dan Quayle came out right after that. Dan was also living in Victoria, BC. He was assessed as having cancer. He was told that there would be treatment for him. He waited 10 weeks before he was put in the queue, right? The waiting queue to receive his cancer treatment. And he waited 10 weeks to receive treatment. By the time the 10 weeks had come up, his cancer had spread to the point where he decided that no, I'm going to die by MAID, euthanasia. So he died on December 5th, 2023. Both cases, it was related to the lack of effective treatment that's available to people. In the case of Allison, of course, that was the story that led to the stories because, of course, she left Canada. Now, if you remember, and I did publish quite a bit about Dan Quayle because his widow was very upset. She made it very clear they couldn't afford to go to the U.S. for treatment. That was not an option for them, no option. And on top of it, uh, this was a situation where he was denied the care he needed. He ended up dying by euthanasia. Well, this is a story that you can't make up. Family of Joan Rowaway. Joan, um, what happened is Joan's family were threatened by the BC Health Authority to have their mother taken from them because they were accused of denying their mother her right to die. So what happened is Joan also had cancer, and she was having a conversation with the oncologist when the oncologist had determined that there was no further medical treatment for Joan. Okay, so I'm not arguing that's very likely the reality. Anyway, the point of it is Joan was at home dying with her daughter and her son-in-law caring for her, and Fraser Health, which is the health authority that they lived in that region, right? Fraser Health, just near Vancouver, contacted them and said, "We are coming to pick up Joan for her MAID death." And the family said, "Joan doesn't believe in euthanasia." Um, and they said, "Well, no, she's been approved for MAID. We're coming to pick her up." They sent two people over to the house to come get Joan, and the family wouldn't let them in the house. And then finally, Fraser Health sent over someone who's a bit more conciliatory, who actually asked Joan, "Do you want euthanasia MAID?" And Joan said no. Now, what happened actually is Joan had admitted at the time very clearly that that conversation about MAID had come up when they were talking about the fact that there was no further treatment for her. But Joan was quite clear she never asked for it. She never actually requested it, but the doctor had approved her for it. So you can see how, and the family also said that Joan at the time of that conversation had been partially sedated, and so therefore the conversation with her oncologist might not have been completely clear. Nonetheless, just imagine someone calling you to come get your mother for MAID. While we've been debating euthanasia for mental illness in Canada, as I explained to you in the beginning, Bill C-7 had approved euthanasia for mental illness in 2021, mental illness alone, and then the government originally put a 2-year moratorium on that. They then extended that moratorium until March of 2024, and then earlier this year they extended it to March of 2027. We have to understand this issue. What is remaining in our law when the terminal illness requirement came out was that you have to have an irremediable medical condition. So the question remains, is a mental illness an irremediable medical condition? This is the question. So anyway, Dr. Sonia Gain, he's important because he is a past president of the Canadian Psychiatric Association. He teaches at the University of Toronto. He's made it very clear that it's impossible to predict whether mental health conditions are irremediable. Okay, the Council of Canadian Academies also concluded that there's no evidence to support providing MAID solely for the reasons of mental illness. So, the country considering this issue, why are they considering this issue of mental illness? Why have we been debating euthanasia for mental illness? Well, there are certain people who say that euthanasia for mental illness is about equality. It's about equality. You should be allowed to have euthanasia if you have a physical illness or if you have a psychological illness. The argument is that people with mental health issues are suffering, and I'm not going to argue that. Certainly, they are suffering, but the point of it is that they would say that they're suffering also in a similar way as people with physical illnesses. So, based on equality, we shouldn't be denying them the quote right to die, if that's what you want to call it. But what was interesting in October of last year, um, there was an article published by Vice. Okay, Vice is like an online sort of magazine type idea. Anyway, and there had been a conference in Victoria, BC, on this issue of euthanasia for mental illness. So the federal government had sponsored this conference, and it was all based on the concept that euthanasia for mental illness was going to come into its legal force as of March of 2024. That was what it was scheduled for, right? And so they had this conference, and the question that this Dr. David Martel was dealing with is, could people be approved for euthanasia for mental illness based on being a drug addict? So drug addiction becoming a reason for euthanasia. So what happened is Dr. David Martel, who was from Nova Scotia, had determined that yes, substance use disorder assessments would be difficult. He said tricky. Nonetheless, it would be an option. He said that certain forms of drug addiction are clearly a form of mental illness. That's how he had described it. Honestly, I never thought of that previous to this report, that drug addiction would become a reason for euthanasia. Now, why is this an important thing to bring up? Canada seems to be having a serious problem with homelessness right now. We see it in all our major cities. If you don't live in a major city, maybe you don't see it too often, but certainly here in London, Ontario, we've got a lot of homelessness. And a lot of those people are experiencing mental health issues. I'm not saying all of them are. Some of them clearly are homeless for different reasons, but a lot of them are clearly going through mental health issues. So the question starts becoming, and a lot of these people have addictions. You can see that it's obvious they have addiction issues. So would euthanasia then become an answer to that problem? Obviously, I don't believe in euthanasia. I don't believe in killing people, but this was the type of question you must ask yourself. In February of 2023, we had the Parliamentary Committee on Euthanasia and Assisted Suicide come up with their report, and they had recommended euthanasia for mature minors and euthanasia by advanced request. Now, you might already know that Quebec has amended their law. So in June of 2023, the Quebec government passed Bill 11, and they added euthanasia by advanced request into their law in Quebec. So Quebec, as you know, has a different law than the rest of Canada. Euthanasia by advanced request is possible now in Quebec. So what that means is that you would then request euthanasia ahead of schedule. It would then be if you became incompetent later on, you had already been approved, right? So it's an advanced request. Um, but if you consider this issue of euthanasia for mature minors, euthanasia by advanced request, these issues really do change the issue of consent. Now, you might remember what blew up in the face of the government was during the whole hearings on this issue by the Parliamentary Committee on Euthanasia, the Quebec College of Physicians came to that committee and they said, yes, we support euthanasia for mature minors, but we also support euthanasia for newborns, which is a totally different question again. And when I say here life unworthy of life, people who know a little bit about the Second World War will know exactly what I'm talking about. Recent Alberta case concerning a 27-year-old autistic woman, MV, who was approved for euthanasia. The father, who's known as WV, of the woman prevented the euthanasia death. Now, how did he do that? He challenged the decision to approve her euthanasia in court, and there was enough question there. So I can get into this because we have intervened in the case. The case has since been dropped. I'm not going to get into all that stuff. But what it was is that the father was clearly claiming that his daughter did not have an irremediable medical condition. She did not qualify under the law. Clearly, she was autistic, yes. She was obviously, sadly, going through a form of suicidal ideation, to say that, to make sort of come together. Nonetheless, the doctor approved her based on unknown causes of pain. It becomes very concerning when someone who's completely otherwise healthy, who has no known actual medical condition, is approved for euthanasia. Now, I have an autistic son who's about the same age as this woman in Alberta. And my reaction to this was actually a form of discrimination. Now, why? If MV were not autistic, she would not have even been considered for euthanasia. But because she was autistic, they had considered her and approved her for euthanasia because she had no other medical conditions. She was not ill. She was not, you start naming the conditions. She doesn't have them. But as an autistic woman who was claiming to be suffering, and I'm not saying she's not going through mental health issues. She's not going. No, I'm not saying that at all. I'm saying that she had no medical condition. She was approved for euthanasia. She's still alive today. Some of you who follow my information would know that she had gone on she stopped eating and drinking for a period of time. She has currently she started again to eat and drink. We hope she recovers. We hope she changes her mind. That's the whole reason for all of this. We don't think that this is ever acceptable. I don't believe in any euthanasia. I don't believe in killing people. But obviously, when you start thinking about these cases, it's just becoming ridiculous. The more recent case just came out in June, just June 17th. Well, that's today's June 25th. Dying with Dignity and the family of Sam O'Neill have launched a charter challenge claiming that their daughter, Sam O'Neill, her charter rights were infringed when she was transferred from St. Paul's Hospital in Vancouver to another facility to die by euthanasia. So let's be clear about the facts. Sam O'Neill died by euthanasia. She was transferred from St. Paul's Hospital. St. Paul's, of course, refused to kill her. She was transferred. The family claims that the forced transfer, as they define it, now there's no forced transfer. Transfers happen all the time. Let's be brutally honest. If you have certain health conditions and your hospital doesn't have an expertise in that health condition, you will often be transferred to another facility who have expertise in that health condition. Now, I don't consider euthanasia health. Nonetheless, you know where I'm getting to. This is not the first time this case came forward because the year before, Dying with Dignity and Sam O'Neill's family launched a campaign to pressure BC Health Minister, Adrian Dix is his name, to force St. Paul's to provide euthanasia. In December 2023, the BC Ministry of Health expropriated property from the Catholic Hospital. So similar to the case of the Delta Hospital Society, the BC Ministry of Health expropriated a piece of property owned by Catholic Healthcare, and they're building a killing center right next to St. Paul's Hospital in Vancouver. Now, that alone to me is ridiculous. If you just saw my previous slides about people not receiving cancer treatment in British Columbia, and yet the BC government would expropriate property and build a killing center right next to St. Paul's Hospital, right off the bat, all of that's pretty insane. But that, of course, was not enough for Dying with Dignity. That was not enough for them. They want to force every publicly funded healthcare entity to do euthanasia. Let's be pretty brutally clear. Many of you might have read articles by people with disabilities saying we need to have safe spaces. Believe me, if every healthcare entity must provide euthanasia, there will be no room for safe spaces for anyone in our system other than in your own home. Okay? EPC is planning to intervene in this case. Intervening in cases is not cheap. Just saying that to you. It's not cheap to do that. That's a very expensive ordeal, but we believe we need to be there. Euthanasia is sold to the culture as enabling personal autonomy and choice. It's my body, my choice. We're told that it's for people who are suffering and nearing death. We're told that euthanasia is not a form of suicide. People are rationally choosing to die. Is this true? No, it's not true. These things are either philosophically wrong or simply not the case. The bigger question is, why do people ask for euthanasia? Most people die by euthanasia because they're going through a difficult health condition. Well, we accept that. They're feeling depressed, lonely. They're experiencing feelings of hopelessness. They believe that their life lacks meaning, purpose, or value. Euthanasia, therefore, is not about freedom, certainly not about choice. It's not about autonomy. It is about abandonment. We're abandoning people at their time of need. These are deaths of despair. Okay. And the problem we're having in Canada is like the Netherlands and Belgium, Canada is debating the expansion of euthanasia to children, to incompetent people by advanced request, people with Alzheimer's dementia, people with mental illness. Well, there's only one clear line in the sand, and that's the problem here. We've crossed that line in the sand, and that is you cannot kill. I'm opposed to killing people. Because once killing is considered an acceptable solution to human problems, the only question remains is who can we kill and for what reasons. Now, I'm going to quickly go through some, I'm going to go to a new share. I'm going to go through some US data. So in the US, you've got 10 states and one jurisdiction have legalized assisted suicide. One of the states is not really legal, and that's Montana. Montana had a court decision in 2009, the Baxter decision. The Montana court did not legalize assisted suicide. What they did is they created defensive consent. So the Montana court said in the Baxter decision that in Montana, a doctor, if they assist a suicide, must prove that there was consent. That's how it works. In the past two years, though, no new state has legalized assisted suicide in the U.S. I'm very proud of that. Currently this year, we're in the same boat. No state has legalized assisted suicide in 2024. The important thing about that is this is an election year. So therefore the legislatures in the US close earlier because they have a November election, right? So there's a good chance we might be able to pull this off in 2024. In 2024, 20 states had legalization bills. 2 states, California and Colorado, had expansion bills because they have already legalized, right? And 2 states had bills to prevent assisted suicide. Nearly every state, though, that has legalized assisted suicide in the U.S. has also expanded their legislation. It's a very important point if you're looking at the U.S. politics. Okay. The assisted suicide lobby in the U.S., what are they trying to do? They're legalizing assisted suicide in more states. They're failing at that, which we're very thankful for. Where it's legal, they're expanding the laws. So what the assisted suicide lobby in the U.S. has found is that it's easier to expand a law in a state where it's legal than to legalize it in a state where it's not legal. So what the assisted suicide lobby is doing in the U.S. is they're trying to legalize in states with bills that appear restrictive, because they know once they legalize, then within a couple years they can expand the law, right? So where it's legal, they're trying to expand the law by eliminating the waiting periods. Well, that's what we had in Canada, right? They want a same-day death. That's what they want in the U.S. They just want to expand assisted suicide. Who can do it? Currently, originally all the states only allowed doctors to do it. I shouldn't say only, but nonetheless, they're adding nurses and doctors' assistants also to the list of killers. The problem they're having in the U.S. is too few doctors are willing to kill. So what do you do when you've got too few doctors willing to kill? You add nurses and doctors' assistants and others to the list, because now you've got more people who are capable of killing, right? They're trying to eliminate the residency requirements. So in Oregon and Vermont, they've eliminated the residency requirements. So therefore, anybody in the world can die by assisted suicide in Oregon and Vermont. They're trying to push for euthanasia. There was a bill in California that would have changed the California law from assisted suicide to euthanasia. They've been launching court cases that claim a right to assisted suicide. They've been failing at that. We're very thankful. There's a new case now launched in Pennsylvania claiming there's a right to assisted suicide. I've read that case. I think it's going to fail. They're trying to permit assisted suicide by telehealth. So what they're doing, so states like Vermont now approve assisted suicide by telehealth. So therefore, you never have to see your physician to get approved to be killed. They're trying to change definitions to allow assisted suicide for chronic conditions rather than terminal conditions, and they're establishing these regional killing centers where they remove the residency requirements. So there's an assisted suicide clinic now in Oregon. In 2024, no new state has legalized assisted suicide yet. That's been a big success. The New Hampshire State House passed their assisted suicide bill by 179 to 176, but the state Senate referred it to study, so it's dead in New Hampshire. So that's really good. I'm not saying it's always going to be dead in New Hampshire, but this is a victory. They can't kill you by assisted suicide in New Hampshire, and that's a good thing. Colorado expanded their assisted suicide law. They're now going to allow advanced practice registered nurses to assist suicides, so they're expanding who can do it. They also reduced the waiting period from 15 days to 7, but they're also allowing the waiting period to be waived. California, well, I'm going to jump by California. The biggest thing about California is the increases. In 2022, there was a 63% increase in assisted suicide deaths in California. I'm going to move on. They had a bill in California, SB 1196, which would have expanded California law by allowing euthanasia. So what they wanted to do is change it to, instead of self-administer, to allowing it to be done by IV. Well, euthanasia is done by IV, right? Someone does it to you, right? Rather than you doing it to yourself. They were trying to remove the 6-month prognosis and replace it with the Canadian definition, grievous and irremediable medical condition. Well, I wouldn't be surprised if there are people on this call who have a grievous and irremediable medical condition. It's pretty wide open, especially if you don't actually define it. Allow people with early stage dementia. The bill said early stage dementia. So what they're saying is, if you have early stage dementia, we're happy to kill you. They're trying to remove, they wanted to remove the California residency requirement that anybody in the world could die by assisted suicide or euthanasia in California. And they also wanted to, okay, so the bill was actually dropped in the California legislature, not because the sponsors and others didn't support it. It was dropped because Compassion Choices, the assisted suicide lobby group, said it was affecting the bills in the other states that had not legalized assisted suicide. So other states that had not legalized assisted suicide, as New Hampshire, etc., who were debating it, they were coming back saying, well, wait a second, we don't want what you're doing in California. And it was affecting that debate. So it was making it harder for them to pass in more states. Okay. Oregon data. So now remember, every year the data in a state in the US, it's underrepresented. I'm not going to get into that too much. Most of you are Canadians, so you probably, it's the same thing with the Canadian laws, is that we have no way to prove it other than in Quebec. Okay. I'm not going to get into that either. You can send me an email or you can call me and I'll explain it to you. In 2023, the Oregon report indicated there was 367 reported assisted suicide deaths, which was up by 21%. It was probably, I'm saying it's probably actually 400. Okay, we'll get into that later. There was then also a bigger increase, though, in the number of people who were approved for assisted suicide. There was a 29% increase in those who were approved for assisted suicide. So there was 566 lethal poison prescriptions written. Now, here's the thing with the US data. So if you're an American, watch this clearly. There were 141 people who received a lethal poison in Oregon in 2023 who had died, but whose ingestion status was unknown. So they knew these people received the lethal drugs, the poison. They knew they died. They had a death certificate. They just didn't know how they died. We don't know how they died. These people may have died by assisted suicide, or some of them may have died by assisted suicide, but nobody knows. So this is the whole issue right off the bat. What's really going on in these states where they've legalized assisted suicide? And is there something different about Canada? I would think Canada's got similar problems, but as I say, there's no reporting to prove it. Meaning our reporting system only looks at the reports that are received from the doctors who do the death. Similar problem in Oregon, but I'll get into it later. 23 of the assisted suicide deaths were out-of-state deaths in 2023. So those were done at the assisted suicide clinic. So here's the other thing about, yeah, I predict there was 400 actually. If you go through, I go through the math at another time. Complications. So they claim there's not many complications with assisted suicide and euthanasia. Now you have to understand, in the US, the doctor is the only one when they're at the death who can report complications. So I said here that there was 367 reported assisted suicide deaths, but there was only 122 reports from the doctors at the death who could have reported complications. That means the doctor was only at the death 102 times. Okay. Out of that, there was 10 known complications. So that's about a 10% complication rate, right? But remember, it's 10% of 102, not 10% of 367. So of those other ones, the doctor wasn't at the death. Now, who's usually at the death when the doctor's not there? It's the assisted suicide lobby volunteer who's at the death, okay? In 2022, there were 7 known complications out of 76 deaths, so it's about a 9% complication rate. Now, we don't get data like this out of Canada because they just don't report it. But what I'm looking at clearly is that the complications seem low, but it's because we don't recognize in the US that the complication rate's only based on the fact that the doctor was at the death and reported the complications. There might have been other complications when the doctor was at the death and the doctor didn't bother reporting them because it would look bad. So there could be even a higher complication rate. So we move on. I'm predicting there was probably actually, minimally speaking, 40 complications in 2023 in Oregon, right? It's sort of important to look at. Most of the assisted suicide bills, as I said before, are what I call Trojan horse bills. So the purpose of the bill is to legalize assisted suicide, because once legal, it's easier to expand the law than it was to legalize it, right? So once a state has legalized assisted suicide, compassionate choices challenges the laws in the court. You see that I can get into that, but the reason in the US they've now got states that dropped the residency requirement is compassionate choices took them to court, okay? And they also challenged the legislature to expand the laws. Okay, some states have more expansive bills. Those states believe that they have votes already in place to present a wider bill. Most of the states, though, have a tighter looking bill. Okay. For instance, the New York bill, the New York assisted suicide bill, looks actually reasonably tight. I'm not saying it is really tight. It looks actually reasonably tight. When you read it through, it's actually, you know, I'm not saying there's anything good about assisted suicide, but they've written it in such a way that to get it passed, right? They have failed to get it passed. But we have to realize that they're looking for a tight bill to get it through, and then they want to expand it later. So for instance, J.M. Sorrell, who's the executive director of Massachusetts Death with Dignity, said on the Massachusetts bill, once you get something passed, you can always work on amendments later. Now, he was commenting on the fact that the bill was quite tightly written, right? Amy Pauline, who's the sponsor of the New York bill, recently stated at an event promoting the bill, we've been criticized by some organizations that actually want an expansion, but we've held firm because we want to get this passed first, right? Want to get it passed first. Josh Elliott, the Connecticut bill sponsor, said he wanted to get a heavily safeguarded assisted suicide bill passed and then make amendments later. Residency required. So Gideons versus Brown was the case in Oregon, where they said that it was unconstitutional to deny assisted suicide to out-of-state residents. Okay. Now, if you consider the argument was based on healthcare. Assisted suicide is actually not healthcare. There's nothing healthcare-ish about it. Okay. These are lethal poison drugs that are given to someone to cause their death. So they said that you cannot deny health care to someone who's an out-of-state resident or someone from out of the state. And that actually sort of makes sense. Like if I had a serious health condition and the expert in that health condition lived in Oregon, then obviously I could go to Oregon to be treated for that health condition to that expert in Oregon, right? And there's nobody in Oregon who would say I wouldn't have the right to go to Oregon for that treatment. But this is assisted suicide. So what happened is instead of the Oregon government defending their law, they in fact then struck down, they removed the residency requirement from their law. Vermont had the same thing happen. Compassionate Choices challenged them in court. And Compassionate Choices currently has a court case launched in New Jersey to strike down their residency requirements. So you see what's going on. The removal of residency requirement means that every American is able to die by assisted suicide now. So even though it's a state-by-state issue in the U.S., they've made it national by removing the residency requirements. Also, the issue of telehealth is important because anyone in America can be approved for assisted suicide remotely by telehealth and then go to Oregon to die. Okay, it's actually Vermont that allows assisted suicide by telehealth. Oregon also has, as I say, an assisted suicide clinic. Dr. Gideons does that. Okay. March 2022, the Colorado Sun published an article about Dr. Jennifer Guardiani, an assisted suicide doctor who had approved at least 3 assisted suicides for the reason of anorexia nervosa. So Guardiani redefined anorexia, which is defined as a chronic condition. She called it a terminal condition in order to do those deaths. In 2021, Oregon, the assisted suicide report also listed anorexia nervosa as a reason for assisted suicide. The other thing is how assisted suicide is done. Okay, so many people don't realize that the assisted suicide lobby has been, since 2015, have been working on finding cheap, effective ways to kill you. Okay, so what they've done is the assisted suicides were originally done by Seconal. Seconal became very hard to get and very expensive in the US to get. The reason for that actually had to do with the issue of capital punishment. The company that produced Seconal was not willing to send Seconal to the US based on the fact that it was also being used for capital punishment, right? So Seconal became very hard to get. So what they did is they started coming up with these other ways to kill you. So the first Seconal alternative was reported in March of 2017 by the Seattle Times as being too harsh, burning patients' mouths and throats, causing them to scream in pain. The second drug mixture that they came up with led to long, stretched out deaths. 31 hours in one case. In fact, last year, the longest death was around 115 hours in Oregon, 115 hours. An article published by The Atlantic in January 2019 stated that an advocacy organization called End of Life Washington, that their medical director of the organization, Robert Wood. Now, why does an assisted suicide group need a medical director? I don't know. I don't quite have that one figured out. Anyway, that they were using a drug mixture with a sedative chloral hydrate to about 70 patients. He said, we know this is going to put you to sleep and we're pretty sure it's going to kill you. It worked, but with a tragic catch. In a few cases, the chloral hydrate burned people's throats, causing severe pain just at the time they expected relief. Medical Express reported September 8th, 2020, a little known secret not publicized by advocates of aid in dying was that while most deaths were speedy, others were very slow. Some lingered for 6 or 9 hours, a few for more than 3 days. As I just said, one last year was 115 hours. Imagine someone dying over 5 days or more, you know, Assisted suicide is clearly not what it appears to be. Many people support assisted suicide based on their fear of dying a bad death. So if you talk to them about it, they'll say, "Oh, I understand there might be problems with this, but I wouldn't want to die a bad death." They're a fear of dying a bad death. So they would say, "I support assisted suicide for that reason." And I'm not talking about the radical assisted suicide supporters who are philosophically a bit warped. I'm talking about the average person, right? I've already gone through that data with you. You don't need to know more about Canada. So how do we fight assisted suicide and euthanasia? I'm still of the belief that we need to call it what it is. In Canada, we've created the term medical aid in dying. Medical aid in dying was created in Canada. It's a created in Canada term. Nothing to be proud of. It's to make you feel better about killing. People say, "Oh, it's not euthanasia, Alex. It's medical aid in dying." Um, hmm. What is medical aid in dying? Hmm. It sounds to me like euthanasia. It's the same thing. It's just a different term to make you feel better. We uh, we need to use the terms that describe what it is. We oppose assisted suicide. We oppose euthanasia. Why? We're opposed to killing people. We need to be willing to say that. I'm opposed to killing people. People will say to me, "Oh, you're a bit heartless, Alex. You oppose euthanasia. You want people to suffer." I don't want you to suffer. I want you to be properly cared for. But I don't believe in killing people. Okay? Creating an exceptions to homicide and manslaughter. Are these good ideas? Is it a good idea to create an exception in your law to homicide or to manslaughter? Think about it. Manslaughter is not a term used in every U.S. state, but certainly the states that are tend to be, how would you say, common law states like Massachusetts, etc. The term manslaughter would come in because that's a common law term. We need a new strategy. We need to be clear. We don't need a new strategy. I'm saying we need to be clear about what this is. We're opposed to killing people. We need to say it. You know, the assisted suicide lobby, they sell it as an autonomous act, right? Everybody just went through this. They say it's my body, my choice. This is a lie. It's not about my body, my choice. Many of these people requesting assisted suicide euthanasia, they have issues related to capacity. They're having difficulty being able to make these decisions. They have issues related to capacity. These people are often experiencing hopelessness, despair. We deal with people all the time on our helpline, actually. And you're talking to people who are seeking euthanasia or been approved for euthanasia. Are they saying it's because I'm suffering? Well, some of them are going through difficult health conditions. There's no question about it. I'm not arguing that. Absolutely they are. But why are they actually wanting to die? That's the essential question. Most often they're wanting to die based on existential questions or based on this hopelessness, this feeling that my life has no meaning. I have no purpose. I have no value. Hopelessness. Do you kill someone because they're hopeless? It's about abandonment. It's not about autonomy. Okay? And this threatens my life. Why does it threaten my life? Because I'm human. We have in 2024, we miss the concept of what it means to be human. We think of ourselves in a more computeristic way. We think of ourselves as having this radical autonomy. I'm capable of making all decisions for myself. And we're not thinking about what it actually is in our human experience that makes us human, what makes us tick. Why do we go through these considerations? But we know it's normal. It's normal. If you're going through a serious illness, it's normal that you might become depressed. That's not abnormal. That's normal. It's normal that you might question your purpose for living when you're going through a difficult time. That's not abnormal. That is normal. That is absolutely normal. It's normal that you might experience existential distress. Does that mean we should kill you? No, no. Situational depression, loss of hope. And then we also, suffering alone is very difficult. It's very difficult. And then today we've got more loneliness than ever before. So we have a lot of people going through difficult times. That's absolutely true. Who are doing so alone and lonely. These are leading reasons why people are asking for their life to be ended. These are human dimensional questions. But what it means to be human is you can't start killing other humans because you're dealing with people at a time when they are vulnerable. So we made a mistake in the past. We talked about vulnerable people and we said, oh, people in wheelchairs, people who are frail, elderly, you know, certain lonely people, poor people, they're vulnerable. No, we're all vulnerable because we're human. We miss the fact of our humanity. We're all vulnerable at times in our life. We all go through vulnerable experiences. And there's my information. If you have any questions, I don't know how. Oh, it's 2:52. I kept you within the time frame. We did okay. I threw a lot at you though. We have about 8 minutes for questions, and you can always email me. It's info@epcc.ca. Not hard to find. And ask me questions. If you haven't joined our Facebook, you should join our Facebook or our Twitter. The fact that you're on this call probably means you're on my email list. Jackie has her hand up.
We've got this at the beginning of life where the eugenic attitude of not allowing a child that has a disability or might have a tough life or may have a short life into the world. And now we've got those who live with disabilities who are at the front end, or our track 2, which is a track 1. Is there a sense that there's this idea of eugenic, or even just sort of population control, or just governments just wanting not to have to pay? You know,
I think the eugenic question is quite important. Now, obviously speaking, the average person doesn't think of it that way. I understand that, but certainly there's a eugenic overtone in the euthanasia lobby. This concept that, like, even the concept right off the bat of saying a newborn. But if you think about these track 2 deaths, these are people who have an irremediable medical condition, but they're not dying in any way, and they're being approved for euthanasia based on their chronic health condition. There's something very eugenic about this. Now, I'm going to say something else to you. I was recently speaking in Germany, and I ended up going to 3 of the euthanasia centers. So these were places that during the Second World War that the German government set up to eliminate. They killed off, you know, thousands and thousands of disabled people at these euthanasia centers. Okay. St. Paul's Hospital had a piece of property expropriated from it, so the BC government could build a killing center right beside the Catholic hospital. So when I went to see those killing centers in Germany, they're now memorials, right? It was just too eerie for me. The intention might be a little different. I'm not going to argue that. Maybe a little different. The outcome is the same. And this paid for by the government. And you know, we just have to think about this, and the feelings, the pain in my stomach just boil as I'm thinking about this, that they're building a killing center like that right beside a Catholic hospital. In this case, it's really no different in my mind to what the Germans did in the Second World War to kill off all those people with disabilities. You know, and remember, the euthanasia of people with disabilities began before the Holocaust of everyone else began.
Oh, yeah, sure.
And people don't understand the history. You have to read the history. They designed the killing in the killing centers for euthanasia. They designed it there to be able to gas these people. They designed the whole way of doing it. And then they exported it into all these other places. They made it bigger because they killed off a lot more people in, you know, those massive killing centers. But I mean, the concept was designed first that way. Anna says she's from Poland. I absolutely agree with her. Well, it's historically what happened. It is exactly the truth. There's more to know about this. The euthanasia lobby, you read this stuff. The doctors who were involved in that euthanasia killing centers, they all then moved to Treblinka and these other places, all those other big killing centers. They were moved out of the euthanasia killing centers into those places because they were experienced killers. It's insane that we forget our history, and we do what we do. We move on. I think well, Gordon has his hand up, but I think Doug had his hand up.
Thank you very much. Great presentation. Alex, we've met before. I'm up in the Diocese of Peterborough. What I'd like to know is the PowerPoint. Is this available on PowerPoint? Because I'd like to take this to the parishioners. As you know, a few people know about this, and then they just turn a blind eye a lot of time.
Yeah. Well, Doug, I'm happy to send you the PowerPoint, but I'm also happy to go to Peterborough to speak, so we can do it either way. Gordon, you're next.
Okay, thank you. So I just wanted to add on to what you were saying to Jackie. Actually, it's not rocket science. We're looking to a transfer from human medicine to veterinary medicine. And it's not, it's because of who the client is. You see, if a patient goes to a doctor, the aim of the patient is to stay well or to survive. But if you look at it as a collective proposition, population herd management, then the parameters change completely. If I belong to somebody the way my dog or my cow supposedly belongs to me, I want to maximize the utility of that animal. And if I'm going to the doctor, if I'm going to the vet, I know exactly what I want. I want the vet to maximize the utility of my herd. Whatever that means, because that's the way we treat that situation. If I go to the doctor with my own child, on the other hand, I have a completely different attitude. So the point is, actually right now, the government is stealing your money, putting it all together to cover health expenses. And they are actually usurping the consumer power. And they're doing what they need to benefit the bottom line of their organization, not what you need as the bottom line as a patient. And I know that's very, very hard for people to even entertain that idea, because our dearest hope is to look after everybody. But we have to redesign our medical safety net in such a way that, yes, okay, that people are looked after if they can't pay for medical care, but that everybody is being cared for as patients.
Yep.
And right now, that's not what is happening. You very obviously see the shift over now. Alex was talking about many things, many interesting things. One of the new frontier for me is the incapable of consent. And it is a very, very, very small, tiny detail that's left now, that you can't euthanize somebody by substituted consent at this time. You need the consent of the person. Well, they get around it with mature minors. They get around with it infanticide. They're going to get around with it by advanced directives. However, in theory, it's supposed to be voluntary. Now, if they can, at the same time, that they're withdrawing care and withdrawing food and water on the basis of substituted consent. So basically, they're already making life-critical decisions on the basis of substituted consent. The logic is, for me, the logic is absolutely unassailable that if killing is medical care, and if we've already passed the hump of doing life-sensitive things on the basis of substituted consent, I have no doubt whatsoever that there will be substituted consent for the euthanasia of the incapable. And that means, when you pause to think about that, that's the evacuation of an entire patient population.
Mm-hmm.
And that, I would say, is you're looking at a five-year window on that, 5 to 10-year window.
I think that if you read my articles, you'll notice me saying quite often that there's only one good thing about what's happening in Canada. There's only one good thing, because it's all horrific, is that other people around the world are seeing it. And it has made a huge difference, massive difference. When I go to these places speaking, they all know about what's happening in Canada. Like, news is not held in our borders. In fact, it gets out of our country easier than it stays in our country, thanks to our laws in Canada dealing with social media. It's harder for me to get a Facebook message out in Canada than to get it outside of Canada. It's just a reality. And I think it's having a massive effect around the world. And I think we have to be willing to call it what it is. A lot of people, we want to change terms. We want to soften it. That sounds too hard. Well, it is sort of hard, and there's nothing nice about it. You're right. And I'm not saying being, wild and crazy, but I'm saying we have to be clear. We have to be clear. And, it's amazing how, I'll give you one, I know we're almost done. It's 3:04 my time. I'm talking to a guy, he calls me up. He's wanting euthanasia. He's calling the helpline. Somebody who's a support of ours has told him you should call that number. So he calls the number. I answered the phone that time. I'm talking to this guy. He has multiple health problems. So, there's no question about this guy having multiple health issues. And I'm listening to it, and I'm emotionally affected by what he's saying. I'm also questioning, why has he not received proper care? Because it does appear by what he's saying that he's not received the care he should be receiving. But nonetheless, I'm listening to him. I'm spending time hearing his story. I'm giving him time. And in the end, I ask him, though, but why do you want a doctor to kill you? Because that's what you're actually asking for. And he's not negative to what I'm saying. Like, I gave him time. I listened to him. I wasn't being disrespectful anyway, but I asked a clear question. And he said, I'm alone. I have no reason to live. I'm alone. I have no reason to live. He didn't say, I'm in so much pain, Alex. I'm not saying he wasn't in pain. Don't get me wrong. I'm not saying he doesn't experience suffering. He said, I'm alone. I have no reason to live. So this is what we have to remember. We have to remember this very clearly, that this is some of the factors really driving this. But I think we have to be honest. We have to be straightforward. We have to be open to people. We have to always speak in a caring and listening manner. But the fact of it is we can make a difference. And in the world, we are making a difference, a massive difference. Sadly, in my own country, we've got a long way to go. You can send me emails anytime, and I'm happy to answer them. Thank you very much. And I'm glad you joined us today, and thank you for sharing this hour with us.